Hey folks, Professor Finn here, and today we're going to be looking at Chapter 8, Anatomical Considerations in your Embalming History, Theory, and Practice, 6th edition text by Sharon Gee-Mascarello. Let's go ahead and get started. All right, let's get the pen up and running here. There we go. All right, move it along. So before we can kind of think about the internal anatomy of the body, we need to kind of visualize where things are and what might be underneath. Once you understand the surface anatomy and where you're looking, you should be able to kind of figure out what is happening underneath there with, some reasonable education. And the first thing, very, very important in funeral service education, whenever we talk about the body, we always refer to it in anatomical position. Standing upright, facing outwards, palms facing the viewer. So what you see here is how we will always refer to a body when we are trying to distinguish ups or downs, lefts or rights, etc., etc., etc. So if you are ever asked to find the guides or limits for veins, just remember it's the opposite of whatever the artery is. So if we say it goes from top to bottom for the artery, then if we ask about the vein, it's bottom to top. We always give the description in the direction blood flows. So what are these things? Anatomical guides, linear guides, and anatomical limits. An anatomical guide is a method of locating a structure by reference to an adjacent, known, or prominent structure. This allows you to kind of figure out, okay, if I can find this, then now that I found that landmark, I should look in this direction and I should find what I'm looking for. That is an anatomical guide, using reference points on the body to locate what you are looking for. Linear guide, a line drawn or visualized on the surface of the skin to represent the approximate location of some deeper lying structure. If we are looking at the surface skin of a human body, we draw a line on it. That is going to tell us where something is underneath, approximately. And finally, the anatomical limit, a point of origin and a point of termination of a structure in relation to adjacent structures. Now, the big difference between the anatomical guide and the anatomical limit. The guide allows you to find what you're looking for using landmarks around it. So, if we were out in a city and I said, hey, what you're looking for is halfway between the Kmart, I'm dating myself, but the Walmart and the Kroger on the same street. If you find the Walmart, you find the Kroger, you should know that somewhere between those two buildings is exactly what you're looking for. What is an anatomical limit? Anatomical limit is the exact point of start and end of what you are looking for precisely. So for instance, instead of saying it's between the Walmart and the Kroger, what I could say is it is between, it extends between Unit 2022 and Unit 2019 on the same side of the road west of North Avenue. I am giving a very specific location. It is between these two items. It starts at the edge of one and it goes to the beginning of the other, exactly where you should be looking. So that spot, that limit, is somewhere in between the Kroger and the Walmart. Okay? Everything's going to be in the same general idea, but when it comes to talking about arteries, for instance, we're talking about a space where a point where that artery begins and where it terminates and becomes something different. When we're talking about the anatomical guide for that artery, it's how to find that, thinking about the fact that we have muscles and bones and things all up in the neck. So if I find this muscle, where would I go to find where that artery should be? Not the exact point in termination, but the general location. That should give you some idea of what these things are. Arguably, me personally, Anatomical guides and linear guides are the most important part for the embalmer because we can use that to find what we are looking for. The anatomical limits are largely academic, telling you where something starts, where something ends, and of practical use for an embalmer, really that is about understanding, okay, if I have a problem over here, it becomes the femoral artery, so I'll just use that rather than raising an iliac. That's really, I think, the benefit of an anatomical limit. If you disagree, that's what the comment section for. Strap on your keyboard and start commenting. So what you would need to be able to do when you are trying to find something like the common carotid and internal jugular. Okay, so the common carotid artery is the artery, and the internal jugular is the vein. You should be able to identify the clavicle. And something that I am always amazed by is if I put scapula and clavicle on a multiple choice question, people will confuse your collarbone with your shoulder. I don't know what it is. It's something in the water, but it happens a lot. So your collarbone, your mandible of your neck, the angle of your jaw, the mastoid process of the temporal bone, the hyoid bone, the sternum, etc., etc., etc. All of these things play into your ability to find this, especially as you're starting off, so that you're able to locate it quickly and get on with business. So first thing we're going to talk about is the anterior triangle of the neck, a line between the middle of the neck, between the tip of the mandible and the sternum. Extend along the anterior border of the SCM, sternocleidomastoid muscle, and then again along the lower margin of the body of the mandible. In the middle of the triangle, you can feel or palpate is another term for feeling, the hyoid bone between the thyroid and cricoid cartilages. So, if you were to get a picture of the upper region of the neck, what you could do is literally follow the directions. A line along the middle of the neck between the tip of the mandible and the sternum. Extend along the anterior border of the SCM, and then along the angle of the jaw. And what you're basically looking for is right inside there. Now, from a practical standpoint, if you can see this muscle right here, that's 99% of the battle from a practical standpoint. If you can't see that muscle as clearly defined as you see it here, that's okay. Because the moment you incise into this area and you open the incision, all you have to do is find that muscle, and that artery will be lying, no ifs, ands, or buts, right along that medial aspect. The vessels in this area are very superficial, and only the skin is covering them, which, like I said, once you make your incision and you open this up, what you're going to find is a little bit of fascia. You pull the fascia out of the way, there's the muscle. You pull the muscle out of the way, you'll see some connective tissue underneath there, and bammo. Your artery, your vein should be staring you in the face. The platysma muscle covers the anterior triangle. By incising through it, the vessels become visible. The sternocleidomastoid muscle attaches to the mastoid process and the manubrium of the sternum. Only the surface of this muscle, on the surface of the muscle, you can identify the external jugular vein. Lying posterior and roughly parallel to the SCM is the carotid sheath. Within the sheath, the artery is medial towards the midline and the vein is lateral. The vagus nerve is between both. When we start talking about arteries and veins, you can feel arteries no matter what. When you see an embalmer going into an incision and poking around with their fingers, they're trying to feel for the artery because you're never going to really be able to feel the vein. So, if you find or get a feel for where the artery is, you have basically found the carotid sheath. You then need to open that sheath and you will have the artery towards the neck, medial, the vein away from the neck, lateral, and the nerve is bundled somewhere in between both. So what is the anatomical guide for the right common carotid artery? It is posterior, it is behind the medial border of the sternocleidomastoid muscle on the respective side of the neck. So the big trick to finding it, the anatomical guide, finding this with reference to some other prominent area that we can see easily is you find that muscle right here. And then as soon as you do, it will be on the medial border on the respective side of the neck. That muscle comes up like this, and it's going to be towards the midline. The linear guide is the respective sternoclavicular articulation to a point over the respective earlobe. So if we start at the articulation, this is where your clavicle and your sternum attach, and then draw a line up to the earlobe. That gives you an idea of where to incise. Now, when you're making your incisions, the goal to a great incision is being able to hide it where people can't see it. And this is why you'll have people do something like a bra strap incision. You have the anterior parallel, you have the posterior parallel. It's all about hiding the incision. And clearly what type of stitch you use to close the incision will make things easier or less easy to hide after the fact. But your artery, if we're looking here, really is about, and I'm going to see if I can clear. Here we go. Let's get back to the pen. Is about this margin, whoops, right on the muscle. So if we were looking at this body in a clinical situation, what I would be wanting to do for demonstration purposes teaching students, okay, I would make my incision quite literally right there, right on the medial aspect. So when I open this up, I can just pull that muscle to the side and I can see that thing staring right through the fascia at me. If I was doing this professionally, I may want to make my incision on the back. That would be probably a wise decision if you wanted to hide it, considering anything you do up here is going to be very visible, especially if they're not going to bring in a high-collared shirt. An absolute safe bet would be to make the incision over the clavicle and then blunt dissect down to not the right common carotid, but maybe something like the supraclavicular or something like that. Other options could be raising an axillary, or in all honesty, if I was looking at something like this where any damage I do to the neck is probably going to be very visible, I wouldn't even be looking at the neck. I'd be down in the leg raising a femoral. It's that simple for me. I see this, I'm going to go raise a femoral because, hey, that's probably going to give me the best result for the family. All things normal, all things considered. So the anatomical limit, where does the right common carotid start and where does it end? The level of the right sternoclavicular articulation and extends to the superior border of the thyroid cartilage. So here is our articulation right there. This is where the artery begins, and then where does it end? It ends right at the cartilage, the superior border of the thyroid cartilage, where it then bifurcates. Okay, it bifurcates into the internal and external carotids. That is why it is called a limit. It is where the common carotid ends and then goes into the internal and external carotid arteries. Those then feed the front of the face and the scalp, and then the other ones feed the inside organs and tissues of the face. So where does it come from? Well, it is a terminal branch of the brachiocephalic artery. Now, this is where the right and left carotids differ. Okay? Everything till now is same side, same descriptions. The origin of the right is from the brachiocephalic. This comes off the arch of the aorta, and then we have our right common carotid. Now, on the left common carotid artery, you can see it comes off the arch of the aorta itself. It is a terminal branch of the arch of the aorta. So that is something that is different between the right versus the left. Now, quick way to remember what is superior and what is inferior. What is on top, what is on the bottom. I call it the belly button rule. If it is the belly button up, vein is superficial, artery is inferior. Artery is deep. Okay, artery is deep. I shouldn't say inferior, it is deep. Belly button up. The vein is first, the artery is second. Belly button down, it's the opposite. The artery is superficial and the vein is deep. The exception to that rule is the kneecap. Okay? The exception to that rule is the kneecap, and the reason for that is the primary incision site is on the back of the knee. So instead of coming through the front, you access that artery through the back so you don't have to go through the patella. And when you are coming from the back, the vein is something you're going to see first. But as it stands in the body for anatomical position, the artery would be on top, the vein would be on the bottom, but because we go through the back, the vein is going to be on the top and the artery is going to be on the bottom. Why are you injecting a kneecap? You probably have a good reason, because otherwise it's not that helpful. Like, you really have to have a complete failure of the leg to be raising that. There are no branches on the common carotid. And all that means is, as your common carotid is coming off of your brachiocephalic, or whether it is the left common carotid, you see that there is nothing coming off of that artery before it terminates into the internal, that's the external, and the internal versions of itself. That is all it means when it says there's no branches, that it is a solid pipe. Why is that important? Because when you start putting pressurized fluid in there, it is not going to be losing pressure to all these side tributaries. It is going to fill and it is going to go. That is why we want to find large arteries without lots of branches, so we're putting the pressure in and the pressure is pushing as far as it can before it starts diffusing. The left common carotid, the anatomical guide is the same. The linear guide is the same. But with the limit, it is the level of the costal cartilage to the superior border of the thyroid cartilage. Now, with the limit, with the left limit, where it terminates is the same, superior border of the thyroid cartilage. That doesn't change. The only thing that changes is where it starts, costal cartilage, because instead of starting up here, okay, do you see that? With the heart, we have the arch coming over. The brachiocephalic has to come off. It starts below. It's a little bit longer because it comes directly off the arch of the aorta. And as it states, its origin is right there, branch off of the arch of the aorta. Once again, the artery is deep, the vein is superficial, and the artery is medial. It is medial. It is closest to the midline of the body. Once again, no branches. It terminates at the bifurcation of the left internal external carotid arteries. Now, it goes into the branches of the left and right external carotid arteries because, of course, we have to ask you questions of things you should know that you're likely never going to use. If you're having to dig that far into the neck, you really need to get with whoever made the incision and started cutting things because you're missing way too much artery there. What's the moral of the story? Okay? You need to visualize where the internal and external carotids are going. The external is going to go into the outside and upper portions of your scalp. Okay? The interior is going to be fed by the internal. So when you see things like the ascending pharyngeal, superior thyroid, lingual, facial, occipital, posterior, auricular, maxillary, and superficial temporal arteries, a lot of these things are on the outside of your skull. Those would be fed by the external. And then things that feed your eyes, like the ophthalmic, anterior cerebral, middle cerebral, posterior communicating, and choroidal branches, those are all on the inside of your skull. That's going into your eyes and into your brain. So, here are the external carotids. You see these things are feeding all sorts of items on the outside of the skull, and the internal are feeding the things going deep inside the head. Sclerotic conditions that occlude the common carotid artery can drastically limit the arterial solution that reaches facial tissues. Fancy way of saying, if this stuff starts to block up because you have plaque growing on the inside of those arteries, that's going to cause you major issues as an embalmer. Okay? Other pathological conditions and traumatic injury may cause this artery to be unsuitable for injection. Fancy way of saying, as the result of trauma or disease, this is not a viable place to use. We might have to try to do something different. This is why it's important to understand what comes off of what in the event you have to go mining to find alternatives. Because the truth is, if these things here are destroyed, you are sorely limited as an embalmer of what you're going to do next to try to get that head preserved. The facial artery may be selected as an alternative to reach the frontal structures of the face, especially the lips and superficial tissues. You can see your facial artery is right here. You follow the line, and what they typically do is make an incision right on the margin of the neck, raise it, and start injecting it. From a professional point of view, you always need to try to find something to inject. No matter how hard it is, no matter how much your life just sucks that day, you have to find something to inject. You have to make an attempt, because the preservation we gain from arterial injection is superior to that of anything that we're trying to get with hypodermic injection or surface packs. So from a professional standpoint, we are under an obligation to try to raise something, inject it, and then rely on supplemental treatments to augment that. To raise the facial artery, an incision is made along the inferior border of the mandible, just anterior to the angle of the jaw. The artery itself is superficial and requires only a small incision and a reduced diameter arterial tube. This one's a bit scary. Okay, this one is a bit scary because any cut you make on the face might be highly visible, which means when you're done, you're going to want to make sure everything is nice and dry. You're going to try to hide that incision, probably using super glue and then pore sealer, so that way you're not leaving a suture, although you could do something like a hidden stitch or something like that. But as you can see, it is very, very, very visible. Following injection, again, they recommend using an adhesive rather than a suture. Next up, we have the axilla, or the axillary artery. So right now, in order to do anything, we're going to have to get that arm out of the way. Okay, we have to get the arm out of the way because we have to get inside your armpit. Borders of the ribs and intercostals, and the anterior and posterior axillary folds. So we have our ribs right here, and then we have a fold. If we reach in here, we can actually grab a fold. If we reach on the other side, we can grab a fold. That is what they are referring to. There are 6 branches of the axillary artery, and the artery is quite large. This is why this artery kind of stinks, because when you go mining in here, look at all the nerves and everything that is bundled up. So even if you're experienced, you might just be having a bad day because that body is a little bit different than others you've worked on, and it might take a little bit more effort for you to figure out what's happening here. So ID the anterior fold by grasping the massive tissue on the contralateral side of the body. So we have medial towards the midline, okay? And we're looking at the anterior fold. We're not really going medial. We're kind of going up and out. So they use contralateral for that. It contains the pectoralis major and minor and the subclavius. So you can see it is this fold right here. There's the posterior. And then you could actually see some ribs. There's the bottom. So we have the axillary space or axillary fossa right there. The posterior fold consists of the latissimus dorsi, the subscapularis, and the teres major muscle. The medial wall is ribs 2 to 6, and their intercostal muscles covered by the serratus anterior. Ribs can usually be palpated even if they aren't seen. The rule of thumb for dogs are your pets at the right body weight. When you touch their sides, you should be able to feel their ribs, but you don't see their ribs. And the serratus anterior is only visible and on workout folks who really put effort into making that visible. On the lateral wall of the axillary space, you'll find the shaft of the humerus, the biceps brachii, and the coracobrachialis. Once again, like the serratus anterior, the coracobrachialis is only visible on very lean muscular subjects. Moral of the story is you're likely not going to be able to see these in the majority of bodies. Okay. So, the cervico-axillary canal is the apex of the axilla bounded by the clavicle, scapula, and first rib. This gives you an idea of where these things are. Now remember, you're seeing this on the top of the body. This is not where you would likely be making an incision to access the axillary artery. You might be making incision over here to access the subclavicular, which, if you're asking me, that might be a more wise decision, simply because of the fact that you don't have to worry about all the branches and crap. And once the brachiocephalic splits off and becomes the right common carotid and the subclavicular, there are no branches coming off of this. This is the only artery, and if you find it, congratulations. So here with the arm abducted, abducted means arm is away from the body, we see the armpit. So here's the anterior fold, here's the posterior fold, there's your ribs, and what you do is right down the middle, right down the center of the axillary space. The axillary sheath contains major structures that leave the neck and pass through the cervico-axillary canal to enter the axilla. With arm abducted, the vein will cover the artery and partially obscure it. Vein on top, artery underneath, just like the neck. Remember the belly button rule. Now, in the brachial plexus, you do have three nerves, the medial, lateral, and posterior. They are surrounding the artery, there to make your life miserable because you think you're raising an artery and you're not, because it's the nerve. Access to the axillary artery can be awkward due to the amount of nerves and other things in this area, let alone keeping the arm abducted. And a great way to do that at the table is to abduct the arm, use the side of your hip to hold the arm open, and then you should be able to access the interior of the axillary space fairly easily because you are the living wall that is preventing the arm from closing. If you're lucky enough to have an apprentice or a resident who can just sit there and hold it for you, that's great. A lot of embalmers have to work solo, so you become your own doorstop. So what is the anatomical guide for the axillary artery? It is behind the medial border of the coracobrachialis muscle. So here's the medial border, and you're going to find that artery somewhere up there. The linear guide is a point over or through the center of the axillary space to a point over or through the center of the lateral border of the base of the axillary space, and the line is parallel to the long axis of the abducted arm. Fancy way of saying is once you see the armpit, you draw a line right through the middle of it, and where the arm begins, that's where the axillary ends, and on this side is where you will have the brachial. Now, me personally, and again, we're just talking about me, and everyone knows that I go for the purple-flavored crayons. I would almost exclusively go in and raise a brachial artery rather than dealing with an armpit because I only have to look for the one thing that's there. There's not a lot of nerves coming off of it and not a lot of extra stuff directing my attention. So, given an option, I am going to raise a bicep brachial muscle, okay? Or a bicep brachial, a brachial muscle. And then when I'm done, I'm going to suture it up, cotton, plastic over that. Good. No one's going to see it unless you're coming in with a tank top. The anatomical limit. Lateral border of the first rib and extends to the inferior border of the tendon of the teres major muscle. Now, it is important, okay? It is important. There are different types of questions you may be asked on guides and limits. And the hardest questions are the ones where they include the guide, the linear guide, and the limit, all for the same artery and ask you which one is which. The much easier questions are the ones where they just throw 3 anatomical limits at you, or 4 anatomical limits at you, and say which one goes with which artery. This is why you want to study your superficial anatomy, because if they're talking about the teres major, and you know that it's on the side of the body, then you know damn well that it's not going to be an artery in the neck or an artery in your leg or something in your wrist. It has to be something in this upper chest. So the only decision you have to make is it talking about the first rib, which means it's still in the chest, or is it talking about this is the start and it drifts down to the antecubital fossa, which is your elbow? And if it does, you know it's talking about the arm, which means it's a brachial. If it talks about the rib, you know it's a chest, so you know it's going to be the axillary. The axillary arteries in general are a continuation of the subclavian arteries. Now, as you can see, subclavian artery is coming through and goes down there. When you make the incision, a lot of people make the incision here and don't realize they have to cut through ribs. You want to make that incision either above the clavicle or on the clavicle and then dissect in to find the subclavian before it goes into the deep end of the armpit. Because remember, this subclavian artery has just split off of the brachiocephalic, because this is your right common carotid right there, and then this is your brachiocephalic. The artery is lateral and deep. The vein is superficial and medial. So when it comes to the medial versus the lateral, these are harder to remember. There is no rule of thumb. You just got to kind of figure out and grind through the ones that you've memorized and hope that you are right when you answer the question. Look at all the branches of the axillary artery: thoracic, thoracoacromial artery, lateral thoracic, subscapular, anterior humeral circumflex, posterior humeral circumflex. Everything here is talking about chest, thorax, 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 shoulder, scapular, and then humerus, upper arm. All of these branches will indicate that they are somewhere in this range. This is why you need to spend time and grind through the suffixes and prefixes so that you understand what these things might be, and that will limit. If you saw thoracoacromial and you decide to say, oh, that might be a branch of the abdominal aorta. Okay, so your abdomen is where your guts are, and this thing is talking about something to do with your thorax and the acromion, which is a bony protuberance. You should know that has nothing to do with your guts. And where do we make the cut? Right down the middle. Right down the middle. So it's right on top of the linear guide. So the brachial artery. This is one of those arteries that's either super easy to find or it's a complete pain in your butt. Not as bad as some of the stuff in the leg, but this can be frustrating on days when you're tired. It just doesn't want to be found. So the anatomical guide for the brachial artery is the bicipital groove at the posterior margin of the medial border of the belly of the biceps brachii muscle. The moral of the story is get the bicep, open things up, find the bicep, and then you find the medial border, and this thing should be right underneath, and there should be a little cutout, a little groove where things fit, and it's passing right through that. The linear guide is the center of the lateral border of the base of the axillary space. Important thing to note. You know, here we have the axillary space, right? The last linear guide we saw was said, hey, point from in here to the lateral border of the axillary space, which means the next one is going to start at the lateral border of the axillary space and then go somewhere else, in this case to a point 1 inch below and in front of the elbow. The limit, the inferior border of the tendon of the teres major muscle, which is where the last one ended, and extends to a point inferior to the antecubital fossa. A point inferior to the antecubital fossa. This is inferior to the antecubital fossa. And obviously it is a continuation of the axillary artery. Almost every mortuary school has that assignment: trace a drop of blood from here to there and back to the heart, so that you understand the relationship of the different arteries so that you know where the blood is going. The vein is lateral and deep, or the artery is lateral and deep, and the vein is medial and superficial. Once again, vein is on top, artery is underneath. The incision is made along the upper 1/3 of the linear guide. Now, this is super important. This is where I think a lot of people have trouble, where I've seen students just like screwing this up in labs and letting them suffer through it, and then I correct them, because when you make the mistake, you'll remember the mistake because life sucked, and then you remember how to fix it. Here's our linear guide, right? And it does not say along the linear guide. It says on the upper 1/3 of the linear guide. So you don't want to go down here where it's going deep into the arm before it splits and goes down towards the wrist. You want to get it just as it's coming out of the armpit. So you want to make that incision as high as possible up in this range, so it's easier to find before it goes into the deep tissues of the arm. The same will be true of the legs. The closer you are to the hip, the easier it is to find that femoral, especially in obese patients. So if you have to go deeper into the leg, you're going to have to really open that incision up because of the fact that you're going to have to go deep into the tissue to find that artery, that femoral artery later. Now, the arteries of the distal forearm are the radial and ulnar. The radial and ulnar arteries. The radial is on the lateral and the ulnar is on the medial. Radials, 2 thumbs up. Okay? 2 thumbs up. The radials are most lateral. And remember, in anatomical position, your hands are palms facing out, so your thumbs are farthest away from the body. 2 thumbs up, radial. Okay? What's important with the radial artery is the styloid process and flexor carpi radialis muscle. Okay, the space between these 2 items is where the artery lies on the anterior surface of the styloid process. And this is the artery that we use to get a pulse. We drop our fingers on our wrist, we feel for the beat, 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 and bam, there it is. The styloid process is the most distal and lateral bony structure, in the forearm. Now, whenever you have these things that, hey, it is the most, it is the first, it is the largest, that is your clue that that might be a piece of important information to memorize for a test. So, distal forearm. First thing, tendons are very long and well defined. You don't have a lot of muscles in that distal forearm. You have a lot of tendons. Because space is a premium, lots of things are layered over each other. The pronator teres tendon is the only tendon that does not reach the distal arm. So you know if that is an exceptional piece of information, it is going to make an exceptional test question. And the pronator quadratus has no long tendon. Another bit of good Tuesday night trivia. So no muscles cross over the artery. No muscles cross over the artery. The brachioradialis overlays the artery. What is unique about these arteries towards the wrist is they do not have a singular vein. They have something called the venae comitatus, the paired veins on the side of the artery. And as you can see here, they are almost indistinguishable, or they are indistinguishable from the artery in as much as they are, they're not separate like we have in the neck, where if you go in there, you raise, you're very clearly going to say, hey, here's the artery, here's the vein, wham. Down here, this gets a bit more tricky. Now, the artery itself is still very identifiable compared to the vein. No ifs, ands, or buts. My suggestion when you are going in here and doing your cutting, you want to make that incision somewhere up here on that lower third of the arm, not at the wrist, where I see a lot of beginners make those incisions. You don't want to do that. One, it's hard to hide an incision here on the wrist. It's a leak hazard, and if you make the incision higher up, it is easier to close it. It is easier to hide it, especially with long sleeves. Now, the ulnar artery is on the pinky side, okay? With the ulnar, you pinky swear. It is always found traveling with the ulnar nerve and will be found in a sheath with the nerve surrounded by the venae comitatus. The anatomical guide for the radial artery is lateral to the tendon of the flexor carpi radialis muscle and medial to the tendon of the brachioradialis muscle. Lateral to the tendon of the flexor carpi radialis and medial to the tendon of the brachioradialis. What is something that you see in both of these names? Literally, the name of the artery is in the muscles. Okay? The linear guide is the center of the antecubital fossa to the center of the base of the index finger. And again, this is your linear guide, but that means you should not be making your incision down here. Make your incision farther back here. Now, the anatomical limit is 1 inch below and in front of the bend of the elbow to a point over the base of the thumb. The base of the thumb is also called the thenar eminence. Okay? The thenar eminence. Your thumb is the thenar. It originates at a bifurcation of the brachial, which means you know damn well that the other bifurcation is going to be the ulnar. And the relationship of the artery to vein is they lie on each side of the artery. Okay, the venae comitatus aren't above or below, they are side by side. So it is along the linear guide at the distal 2/3 of the forearm. Again, not over the wrist, distal 2/3 of the forearm. Ulnar artery. Lateral to the tendon of the flexor carpi ulnaris muscle between the flexi carpi ulnaris and the flexor digitorum superficialis. Oh man, I can't talk today. But what's the important thing? The word ulnar appears in 2 of those muscles. So with the anatomical guide, you just look for the one that has the ulnaris muscles in it, and that's probably the one you're looking for. The linear guide, center of the antecubital fossa to a point between the 4th and 5th fingers. That is your pinky and your ring fingers. And then the limit is 1 inch below and in front of the bend of the elbow to a point over the pisiform bone, which is the hypothenar, the below thenar eminence. And if your hand is in anatomical position, hypothenar is on the bottom. Once again, the ulnar artery is a bifurcation of the brachial. So if you look up here, you see here is our elbow. Here is the brachial artery coming down from the axillary artery, and it bifurcates into the radial and the ulnar. No difference with the relationship of artery to vein. Now, the incision, along with the linear guide, 2/3 up from the distal forearm, 1/3 down from the wrist to expose the flexor carpi ulnaris muscle, then pull the muscle medial. Notice, here is your thumb. Okay, your thumb is coming off right here. This is where you make the cut, the incision for the radial. Right on the other side of the tendons is where you make the cut for the other one. Deep breath. Okay, deep breath. Let's look at the arteries of the body trunk. So first we have the ascending aorta. This originates at the left ventricle, basically the aortic semilunar valve. Now, something important is the aortic semilunar valve is engineered to shut. Okay, it's engineered to shut when it feels backflow. That is the way your heart is engineered. So when we inject, that valve should close, thus forcing the arch of the aorta to fill. The ascending aorta is used in the embalming of infants because we're going to open up the thorax and we're going to go directly there because everything on an infant is small, which means this is probably one of the largest arteries you're going to be able to access, and that's good for you as an embalmer. Can be used if available in the injection of an autopsied case, And it only has really two branches, the left and right coronary artery. And where do we make the incision? Mid-sternal incision. We cut right down the middle on infants. And that is only if the child is young enough that it is still cartilage. If this has been calcified, it's turned into bone, you really don't want to try to saw through that. That's really out of your wheelhouse. And if that is calcified, chances are pretty good you're going to be able to use other arteries like normal adult arteries, probably femorals, carotid, stuff like that. So we have the heart. Okay, we have the heart. You see that there. Then we have the arch of the aorta. Okay, attached to. What I'm probably going to have to do here is I'm just going to have to switch colors very quickly. Let's go to yellow. Okay, here's our ascending aorta. You can see it is a very small chunk. So there's the ascending aorta that we just talked about. And then comes the arch of the aorta. Then comes the arch of the aorta. It is the center of arterial distribution. When we start injecting from a normal point, such as the right common carotid, what should be happening, okay, and we're going to switch colors up here again. Let's go to blue. What should be happening is your arterial solution is coming in via your injection point. It comes down here. It hits the arch. It hits the ascending aorta. Your heart feels the backflow, okay? It's engineered to shut when it feels backflow. So the valve, aortic semilunar valve, closes, which then forces the pressure to seek out paths of least resistance, and it starts going everywhere else. That is the entire principle of embalming. So what are the branches of the arch of the aorta? We've already covered two of them, the brachiocephalic and the left common carotid. The last one is the left subclavian. The last one is the left subclavian. Now, the right subclavian artery, the right, begins at the right sternoclavicular articulation, which is going to be up here. Okay, that is going to be up here somewhere. It extends to the lateral border of the first rib, where it becomes the axillary, right? In the autopsied case with neck removed, these branches need to be clamped. That's the moral of the story, is if we have an open body, they've likely severed the vertebral, the internal thoracic, and the inferior thyroid. Now, for classroom purposes, knowing the names is nice. From a practical purpose, you're going to insert your arterial tube, clamp it off, start injecting, and then when you see the little fountains of Versailles spraying out, you're going to grab yourself some locking forceps, some arterial hemostats, whatever you got lying around, and you're going to start clamping those holes to keep that pressure in. The left subclavian, okay, the left subclavian begins at the level of the second costal cartilage. Notice it is the same level as your left common carotid, and extends to the lateral border of the first rib, where once again it becomes the axillary artery. Unlike its cousin, the right subclavian, this has no branches. This has no branches. Now, from an autopsy point of view, if you're needing to feed something into the arms, no need to make extra cuts. If you can find one of these things kind of dangling inside the thorax cavity, by all means use it. By all means, pick it up, insert an arterial tube, clamp it off, and inject the arm. That way you don't have to deal with any of the extra drama that's going to happen in the armpit. And that's the way the most efficient embalmers work, is they use what they have available, clamp things off accordingly. And if it means you might have to dissect a little to get to an unobstructed or unmarked piece so that you can use it more effectively, then by all means do that internally, because if it leaks, it's going to leak inside the thorax. Let's talk about the descending thoracic artery, intercostal arteries. So the thoracic intercostal arteries are exactly that. Your chest, rib arteries, right? Because your intercostal muscles are in your ribs. You have 9 pairs of these things. So here is a great little chart kind of showing where those are at, which goes into the abdominal aorta and its branches, which have even more branches and fun things. Now, when we are injecting, okay, when we are injecting, remember, this fluid is coming off, it's going up here, right, because the heart stopped. Remember, the valve closed, the aortic semilunar valve closed. It's going to flow a little bit into the head. Little bit maybe might get into the head. But what it's going to find is it has a path of least resistance going this way. So this is going to go into the arm. This is going to go into your left arm. This is going to feed some of the superficial tissues on the shoulder. Then it's going to start coming down here. And then look what it does. It goes into all 9 of these branches. Look at that. All 9 of these branches. And the entire time, it's filling and creeping and creeping and creeping and creeping and creeping. We want it to perfuse as gently as possible. Fill as much of this as possible because we want all of these branches to fill. We're relying on that because that's what's going to give us the most thorough preservation and disinfection of the human remains. And then it's going to continue coming down. And it's going to do the same exact thing until finally it splits and it starts going into the legs and the back lower spine. And once again, you have all of these things on the side. And what these are going to do is these are going to feed the inside and outside tissues of the abdomen. So the descending abdominal aorta extends from the diaphragm to the lower border of the fourth lumbar vertebra. We use this in the embalming of infants. We will cover that later in the course. And if necessary, we can use this in a posted case. We have an autopsy. One of the coolest things and easiest things when you get a posted case is if they haven't really gone in here and butchered too much during the autopsy, you might be lucky. This thing is severed right around there. All this is missing. Like all this stuff up here is just gone. It doesn't exist because there's no guts or anything on a fully autopsied body. But what you're left with is these are probably cut here, that's probably cut there, but you could put in your arterial tube, the biggest one you have, clamp all this stuff off, and then start injecting. And it's going to shoot both your legs at the same exact time. The injection is going to get to both legs, no ifs, ands, or buts, at the same exact time. And if you don't have any trauma or other problems going on in those legs, you didn't have to inject 2 separate places if you didn't want to. You could just go ahead and start with the big one and hope it works. Nothing says you can't do that. Those are some of the practical things that you start doing as an embalmer, because if you can get excellent preservation using one location, all the better for you. All the better for you. And if you realize it's not working, the most important thing you can do is stop what you're doing, raise over here, and inject the legs separately. So that way you know that should be working the way it's supposed to. And if not, then you address that as well. So the descending abdominal aorta parietal branches, this is going to feed the back of the body. So think about what we're talking about here. The inferior phrenic, suprarenals, lumbar, middle sacral. These are things that are going to feed organs and tissues in the back of the body. We also have unpaired branches. So these only come off in one direction. They do not have someone on the other side to match them. That is the celiac, the superior and inferior mesenteric arteries. So the good news is you only have to memorize celiac axis and mesenteric. And remember with mesenteric, there's an upper and a lower. You then had the visceral or paired branches, middle suprarenals, renals, internal spermatic or ovarian, and the common iliacs. These are feeding things basically on the front of the body, the intestines, the sexual reproductive organs, etc. So if we have to incise into the abdominal aorta, if we have to incise into this area, we're going to cut right down the center of the body. Period. End of story. Maybe just left of the midline, but ultimately down the middle. And why is it left of the midline? So you don't cut through the umbilicus, so you don't cut through the belly button, which would be kind of a nightmare to have to suture up later. So you want to suture in as much of a straight line as possible. So this is why you're just not going to cut through the belly button. Now, external iliac. The common iliac artery is a continuation of the abdominal aorta. It then bifurcates into the internal and external iliac artery. The external and internal iliacs are a continuation of the common iliac artery. Why is this important when you are injecting into the iliacs to maybe shoot towards the legs, inject towards the feet, then turn it around and inject in the other direction? In case you are in the external iliac and you don't know it. Okay? Here is your abdominal aorta. Here is your common iliac. And right here you can see the split. Okay, right here you can see the split. This artery inside the internal iliac, this is what's going to feed the tissues of the buttocks. So if you want to get preservative in there, you have to make sure that fluid is getting into that artery. And if you are too far south in injecting this way only, nothing goes into that direction. So you really want to make sure that if you are injecting from only a leg or you're treating a single area, maybe have you just to push a little bit in the opposite direction, just to make sure that you're getting it into that artery. And that is true even if you've injected from a common carotid primary injection site. The reason being is if you're having distribution problems into the leg, I'm not saying that the internal iliacs are all going to have problems. It's just one more thing that you can spend an extra 3 minutes of doing and ensure that you did it for specifically this reason that you had problems getting stuff into the legs. Now, the external iliac lies exactly at the inguinal ligament lateral to the external iliac vein. Fancy way of saying is when you reach the bottom of the hip, so this is the bottom portion, the inferior margin of your hip bone. There's no holes where stuff kind of go through the bone. What they do is they just come up, over, and down. As a result, anything that is coming down into your leg has to basically pass over that bone. So your vein, your artery, your nerves, all of these things are kind of sitting side by side so that nothing pinches the other. This is used for the injection in autopsied or obese unautopsied bodies because it's easier to get because it's right on top of the bone. It is very superficial. So if you ever want to do some damage, you don't want to make the cut really on the leg. You want to make the cut as close to the hip as possible because then you're severing the iliac and that person's going to bleed out pretty dang quick. Sometimes referred to as the iliofemoral or iliofemoral to indicate the use of the site where it becomes the femoral artery. You know, we've talked about these limits, that artery goes up to here, then there's the border, and then it becomes something different. The word iliofemoral basically says that this is where we're actually trying to get, that this is the ideal spot to find, especially when injecting obese clinical cases. So in the inguinal region, the area below the inguinal ligament in which the femoral vessels lie, you must rely on bony landmarks as the subcutaneous tissue masks the area. Basically, find bone, bone will tell you where you need to go from there. So what are the landmarks? Superior spine of the ilium, the pubic tubercle, and both landmarks serve as attachments for the inguinal ligament. So the external iliac anatomical guide, it lies anteriorly and medially in relation to the peritoneum. That is absolutely useless, other than it lies in front and closer to the midline in relationship to the peritoneum, which is the webbing that holds your guts in. So you have your superficial skin, you have your fat layer, and then underneath that you have this rigid webbing called the peritoneum, which helps keeps all of your organs in place. Your artery is just above and just to the midline of your peritoneum. The linear guide is an imaginary line extending upward from the linear guide of the femoral artery. Again, useless. So what do we have here? Here we have the buttock, we have the hip. Okay, so we're going to say here's the hip. Okay, here's the hip. This is where the leg is coming down. And there's no real way to get the linear guide for this. So what you do is actually you find the femoral artery and you work your way back up, is what they're saying. So one thing you notice about this patient, you know, you're analyzing every case, you can see that we have what looks like a scar right here, which means this person probably had hip replacement surgery. The anatomical limit lies from the bifurcation of the celiac artery and extends to a point beneath the inguinal ligament. The artery lies at exactly the same level as the inguinal ligament and lateral to the vein. So there is no superior or deep. They are on the same plane. This is essentially the same as what we found in the wrist. Now, the vein is more medial. The vein is more medial than the artery is. Now, you can find the femoral vessels by placing a thumb on the left hand, on the right anterior superior iliac spine, and the left middle finger on the right pubic tubercle. The index finger should cut the space between the thumb and middle finger in half, and the tip of the index finger will indicate the approximate position of the femoral vessels. So if we go back over here, let's erase all ink on the slide. What they're essentially saying is if you put your thumb over here, your middle finger right here, what should happen is your finger, your pointy finger, should literally be just shooting right down the leg. Okay? That is what they are saying. Now, this is absolutely something that embalmers have taught their apprentices and residents and interns forever. Me personally, after you've done about 30 or 40 femoral arteries, you kind of just look at a leg and know where something is going to be. And what I would do, in all honesty, is I isolate my leg, right? And then I go in, kind of the general area. We're going to talk about the femoral triangle here in a second. And I go in and I kind of grip it with my hand. And I let go, and I kind of try to judge where the muscles are, because we're going to see they form a triangle. Once I find that triangle, I don't need to guess or place my hand or kind of hope. I know that that artery is shooting straight through the center of that triangle. And we'll see that here in a second. Then obviously, if you are on the other side of the body, swap hands. So if you're on the right side, use your left hand. If you're on the left side, use your right hand to put your thumb, middle finger in place, and then you go from there. Now, here's what I was talking about. Okay, femoral triangle, the inguinal ligament serves as the base. Okay, so the inguinal ligament basically runs the entire space of your of the margin of the hip. Then you have the medial border of the sartorius muscle, okay? The medial border of the sartorius. And then you have the lateral border of the adductor longus. So remember what I said. What I'm trying to do is I am looking for this depression right there. Do you see that? There is a depression right there in the center of that triangle. I'm going to highlight it again. Right there. This is what I'm looking for. And if I have that, I know that if I make my incision right there, I will be right on top of my femoral sheath. The roof is fascia lata, which is a dense sheet of connective tissue. You cut through this, okay, which will then expose the contents of the triangle. So you're cutting through the skin, you're going through the fat layer, you find this basically connective tissue layer, you cut through it, and then once you're there, you should see the muscles very clearly. And all you have to do is kind of push them out of the way. On the surface of the fascia lata is the great saphenous vein. Don't confuse that with the femoral vein, because the femoral vein is connected in the same place as your femoral artery. And you may be tempted to see this like, oh, you know, my arteries right are going to be around here. No. Okay? The great saphenous vein disappears through an opening in the fascia lata called the fossa ovalis. If you follow that vein through the hole, through the rabbit hole, it will take you exactly where you want to go. But the moral of the story is you got to cut through that fascia lata. There may be lymph nodes in the area. When you see a hiatus, that's a medical way of saying the word hole, which you may have to cut through the lymph nodes in order to get to what you're looking for. That's true. It's also why femoral incisions tend to be little leaky messes, and you have to go in and cauterize afterwards. Not all of them, but more often than not. Femoral vessels located in the femoral sheath. You have an artery, vein, and then lymph vessels and nodes. So here's a great little example of what we're looking at here. So here's your sartorius. There's your adductor longus. Remember what I said? You're looking for this line right down the middle. And this is the fun part. When you find these two muscles where they literally connect to each other, all you have to do is look right there. You literally just look where the two muscles intersect each other, and you know 100% your femoral artery is right there. It has to be. It's the only place for it. The best approach is 1 to 2 inches from the base of the femoral triangle where they lie side by side. As they approach the apex of the knee, as they approach the apex, the knee of the triangle, their relationship shift. Anterior, posterior, they swap top to bottom, and access is difficult. Moral of the story is you always want to make your cuts in the leg, the femoral artery, towards the top, not towards the knee. That's what they're trying to say. The femoral nerve is located outside the sheath and is the most lateral structure at the base of the femoral triangle. So the nerve itself is actually not part of the sheath like we've seen up top. It is by itself, self-standing, and it is the farthest away from the midline of the body in that area. The floor of the triangle is entirely muscular and composes 2 or 3 muscles depending on who you read. We will use all 3 because Mayer does, and that is the iliopsoas, the pectineus, and the lateral border of the adductor longus muscle. Fancy way of saying that when you cut through the fascia lata and you find the muscles, you will find the artery right at that little V that I showed you. And if you go any deeper, you just run into more muscle, like you've bypassed it. So if you see muscles under the muscles, you have to come back up more superficial. You've gone too far. The anatomical guide for the femoral artery. It passes through the center of the femoral triangle and bounded laterally by the medial border of the sartorius muscle and medially by the adductor longus. All you have to remember is here is your adductor longus. Okay. Why is it doing that? I hate it when it does that. So here is your adductor longus. I think this is the cutout of the sartorius. Is it? Yeah. Yeah, they cut away the sartorius. So your sartorius would be right here. Here's your adductor longus. And what did I tell you? Right where these two muscles meet, that's where your artery is staring you in the face. So that's the anatomical guide. I find raising femorals to be much easier than carotids just because of the fact that after I'm done, I don't have to worry about someone looking at the leg. Like most of the cases, we're not putting people in shorts. The linear guide is the center of the inguinal ligament. Remember, the ligament is coming like this. It runs the entire basic length of the hip to the center of the medial prominence of the medial condyle of the femur. Basically, from the center of the ligament all the way down to the medial point of the knee. And the limit, again, starts at the inguinal ligament to the opening in the adductor magnus muscle. So we had the adductor longus. Okay, we have the adductor longus. And then there's also the adductor magnus, which is this muscle right here. You don't really see it. And that's because there has to be a hole somewhere so that the veins and the arteries can pass through unoccluded so that you get blood and nutrients to the lower part of your leg. The femoral is a continuation of the external iliac. The internal iliacs feed your buttocks and all those deeper tissues in the back. The artery lies lateral and superficial. Belly button rule. Belly button down, artery is superficial, vein is deep. At the linear guide, the incision is made through the fascia lata. So here is one muscle, here's the other muscle. Wait a second here. There's one muscle, there's the other muscle. And if we make the cut, this might be a little bit off center. It should be literally right there. Now, There are branches of the femoral artery: superficial epigastric, superficial circumiliac, and external pudendal and profunda femoris. These, all I can tell you is, have fun memorizing them. They sound like they should be higher. Okay, they sound like they should be higher, but fact of the matter is, the profunda femoris gives it away for you, and you just have to know that the superficial circumflex iliac is a branch of the femoral artery. It's not part of the iliac anything. So now we're past the femoral. We're going to the popliteal. There are two sets of tendons and two muscle heads that form a trapezoid and are described in two different triangles, the upper femoral and the lower tibial. Okay, so you can see that there is one triangle here, there is one triangle here. If you were using a 5th edition of the embalming book, it talks about this as also being a femoral triangle. So in the 6th edition, they clarified this. This, I think, is one of the things that I talked to Sharon Gee-Mascarello about way back in the day, is yo, this is confusing. And we are looking at this from the back of the knee. Okay, so your patella is actually in front, and we are looking towards the back of the knee. Now, the popliteal fossa is bounded laterally by both heads of the biceps femoris and medially by the tendons of the semimembranosus and semitendinosus muscles. The lower tibial triangle is bounded by the medial heads of the gastrocnemius and laterally by the plantaris. So here are your gastrocnemius. Okay. There's your gastrocnemius. Both triangles have an imaginary line drawn down as the base through the middle of the joint. Again, I am not a fan of raising this. I know some people do this. This is not something you should be doing on a regular basis. That's just my take on this. Feel free to disagree by blowing up my comment section. I can tell you professionally, I have never raised this on a paying client. Not for any reason at any point in my career, period. And I think I raised it in labs once or twice. That might say something about my lab style, but with ranked beginners, I want them learning on stuff they're actually going to use and get good at. Once they know what an artery feels like and looks like, and they've mastered the big ones, now they can start looking at some of the obscure things. There is a roof of deep fascia, subcutaneous tissue, and skin. You have to cut through both the skin and the fascia. So just like in the upper leg, you have to make an initial incision, open it up, cut through the next level of connective tissue, and finally you should be in the general area. The major contents of the fossa are the tibial and perineal nerves and their branches, the popliteal vein and tributaries, popliteal artery and branches, and fat and lymphatic tissue. So from the back of the knee, you have the nerves, you have the vein, and the vein is the deepest structure from the top of the knee. So the floor of the fossa, deep of the artery, the floor is formed by the lower end of the femur and portion of the capsule surrounding the knee joint. Remember, when we refer to things being an anatomical position, the knees are facing us. The knees are facing us. So when we say it is deepest portion of the knee, from the front, that vein is right up at the back. When we are incising and coming in from the rear, it's one of the first things we're going to see because we're coming in from the back. So the anatomical guide for the popliteal is between the popliteal surface of the femur and the oblique popliteal ligament. And for the love of God, you should not have any trouble whatsoever knowing that this is somewhere in the knee, since, again, the name of the artery appears literally in the anatomical guide. The linear guide is the center of the superior border of the popliteal space, parallel to the long axis of the lower extremity to the center of the inferior border of the popliteal space. Fancy way of saying, find the popliteal space. It's the line at the top, line at the bottom, going in the direction of the leg as it extends down. Makes it sound so much more difficult in doctor speak. But that's all it's saying is center of the superior border of the popliteal space, parallel to the long axis of the leg, which means parallel to the leg, period, to the center of the inferior border, and there's your linear guide. It is quite common for some embalmers who like to show off their skills and mastery of this artery to approach it from the side. They cut from the side, they go in this way. I worked with an embalmer at Miami-Dade College by the name of John Collar Loera. That's what he would do to access this artery. And he asked me what I did, and I just told him I never do it. Period. I just don't raise it. If I get stuck in the situation where I have an issue here, I either come at the top and inject this way, or I come down here to a tibial and I inject that way. That's how I solve the problem. I don't see a reason for me to have to play around trying to one-man a person from the back, which is why they invented the side incision, because single embalmers have trouble getting to the back of the knee. So the anatomical limit, the femoral ended at the opening of the adductor magnus, and this comes down to the lower border of the popliteus. And it is a continuation of the femoral artery. The vein lies posterior and medial to the artery. The vein can also be described as lying superficial to the artery, because remember, when it says it's superficial to the artery, it is because it is from the back. If you are coming from the front, it is going to be posterior. And despite this being a pain in the butt and small to begin with, it has branches, 5 pairs of genicular arteries and 5 muscular branches. So when you're in there, there's lots of little other things that come off of this. Again, I would rather just raise a tibial. There's only one. The only thing that comes off of that is itself. It terminates at the ankle. The popliteal bifurcates in the anterior and posterior tibial arteries. This is one of those arteries you also have to love to hate. Some days you can just raise them in your sleep. Other days you can't find them to save your own life. The anterior is the most superficial, so it is a convenient injection site. That is true. If I have to go play in the leg, I will definitely raise an anterior tibial artery. Both arteries become superficial near the distal foot and can be used for foot injection. And that's a fancy way of saying this is where you should be injecting this artery anyways, because I see a lot of people try to raise it here in the middle of the leg. Not really the best place for it. It may be deep in the tissues, but as it comes to the front to go into the foot, much easier to locate and take care of it. So the anterior is a smaller terminal branch of the popliteal. It is the smaller of the 2 tibials, and it becomes the dorsalis pedis. It becomes the dorsal fin of the foot. It is on the front. The posterior tibial becomes the medial and lateral plantar. You plant your foot, heel of the foot, becomes the medial and lateral plantar arteries. There is a groove between the tibialis anterior muscle and the tendon of the extensor hallucis longus muscle. That's where you're going to find the artery. That is its anatomical guide. The linear guide is lateral border of the patella to the anterior surface of the ankle joint. So the outer border of the kneecap to the front surface of the ankle joint. Start on the outside, and then you work your way down. The limit is the inferior border of the popliteus muscle, which is where the popliteus ended, to a point in front of the middle of the ankle joint on the respective sides. The artery is superficial to the vein. Belly button rule applies. The vein is deep to the artery, and we do access this normally coming down from the top. For the foot, the anterior tibial, the incision is just above the ankle joint, just like I told you folks, because of the fact that that way you can shoot up the leg or down into the foot. The anatomical guide, the posterior border of the tibia and the calcaneus tendon. Now we're on to the tibial, okay, the posterior border of the tibia and the calcaneus tendon. The linear guide is center of the popliteal space to a point midway between the medial malleolus and the calcaneus bone. Look at the anatomy of the bones of the foot. You'll figure out exactly where it's going if you know the names of the bones. And the limit is the inferior border of the popliteus muscle to a point over in between the medial malleolus and the calcaneus of the respective foot. It is very hard to confuse the anterior and posterior tibials if you simply know what the calcaneus is and if you know what the dorsalis is. It is very, very easy to keep them separate. There is no difference. The artery is superficial to the vein. The vein is deep to the artery. There are some tibial branches, the right and left perineal branches, right and left dorsalis pedis arteries. realistically, again, you're not raising these for primary injections. You're raising these arteries on nearly all the cases you'll ever raise this as a supplementary injection. Yes, I know you can use any artery to inject the entire body. This is not a practical artery for that purpose. The amount of time this would consume, because it is such a small artery, just not worth it. Unless you are getting paid by the hour and like you want to milk the clock. So the foot, the anterior tibial and deep peroneal nerve pass deep into the foot underneath the superior inferior extensor reticula. Oh boy. Inferior extensor reticula or fascia, which are interior to the ankle. I speak good towards the end of this lecture. The skin is loose and the subcutaneous tissue permits easy visualization of arteries and veins. Now, the dorsalis pedis, there is no anatomical guide that we have for the dorsalis pedis. The linear guide is the center of the anterior surface of the ankle joint to a point between the first and second toes. That's your big toe and the one next to it. The limit begins at the level of the right ankle, right where you made the other one, and terminates at the toenail. The incision is midway between the medial malleolus, the medial and lateral malleoli, and the interosseous space. Now, I raised this once in mortuary school. I never did it again. This, again, is probably one of those useless arteries you raise to prove that you can do it and you have skills and you, quote-unquote, got good. I'm sure, again, people are going to disagree that, I use this all the time. Good for you. When it comes to preservation of the feet, unless you're doing something in maybe the Hindu faith tradition, you're probably not going to have bare feet visible. The vast majority of embalmers will probably try to inject a foot via the anterior tibial or the dorsalis pedis. If they're injecting a little bit lower, it's technically whatever. But as you can see, they've made, what I see and what usually I see people raise is they try to raise it right around here. They try to raise it right on the top of the foot. And that's not really where you want to go. You want to keep it right at the ankle where you see it here. And the reason for that is, again, you can inject the leg, turn around, inject the foot if you need to. And if you can't, at that point, really, you're just going to have to rely on supplemental injections and cavity compresses to preserve what you have. Then put a stocking on it, put in preservative powder and absorbent materials if necessary, and tape it shut. All right, folks, that's that. We'll see you next lecture.